So we believe that the combination of a drug called a SHP2 inhibitor in combination with a KRAS G12C inhibitor can improve treatment outcomes for patients with non-small cell lung cancer by enhancing target engagement of KRAS, as well as by inhibiting MAP kinase pathway reactivation following G12C inhibition. So during my talk, I presented the initial results of the dose escalation cohort of patients with advanced solid tumors treated with JDQ443, a KRAS G12C inhibitor, and TNO155, a SHP2 inhibitor in the KontRASt-01 trial. So in this study, 50 patients were treated across 6 dose levels. The dosing regimen for JDQ443 ranged between 200 to 400 once or twice daily continuous, and TNO155 was dosed at either 20 or 40 milligrams once or twice daily, either continuous or 2 weeks on, 1 week off. The majority of the patients in this cohort had non-small cell lung cancer, so 48%, and about half of them had been previously treated with a KRAS G12C inhibitor. What we show is that 88% of the patients had treatment-related adverse events, and 37% had grade 3-4 treatment-related AEs. There were no grade 5 treatment-related AEs across all dose levels studied. At the dose regimen that was selected for expansion, so JDQ443 200 milligrams BID continuous, and TNO155 10 milligrams BID 2 weeks on, 1 week off, 27% of patients had grade 3-4 treatment-related AEs. Increase in transaminases was reported in up to 14% of patients, and only 2% had grade 3-4 increase in transaminases. There were no occurrences of pneumonitis across all the dose levels studied. What we also reported is that the responses were observed both in G12C inhibitor naive and G12C inhibitor pre-treated patients, with a confirmed objective response rate in both groups of 33.3%. The disease control rate was 66.7% in the KRAS G12C pre-treated population. And in the KRAS G12C naive population, it was 83%. Durable responses were observed both in G12C inhibitor naive and G12C inhibitor pre-treated patients, with some responses lasting for up to 6 months, and some patients remaining on study up to or over a year. So in essence, that's the summary of this talk, was that this combination of JDQ443 and TNO155 had a manageable safety profile. The dose regimen that was selected for expansion was JDQ443 200 milligrams BID, continuous, and TNO155 10 milligrams BID 2 weeks on, 1 week off. Responses were observed, like I mentioned before, in G12C inhibitor naive and pre-treated patients. And of note, the confirmed objective response rate was 33% in a KRAS G12C inhibitor pre-treated population, and the disease control rate was 66.7%. And enrollment to the expansion cohorts of the KontRASt-01 study is ongoing.